Okay. Hi, I'm Will Flannery. I'm an ENT consultant, Deputy Chief Clinical Information Officer. I'm Head of Institute for the Health Data Institute. I'm visiting fellow in computer science at the University of Reading. And I want to talk about using NHS health data for research. What's the button? No. Left and right. Right. Oh, yeah, it's right. Okay. So I'd like to talk about two things: understanding how and why NHS health data is collected, and then negotiating the regulatory hurdles that stop us deploying AI at the bedside. Can you see that? Oh, it's got something over the top of it. Okay, so this golden orb at the top is our data warehouse, back end of EPR. It's got an awful lot of data in it. We call it our EPR data warehouse. In the terms of the data access policy, they talk about NHS health data. Thank you. NHS health data, which I'm going to use because it's not all about confidential patient information. There's a lot of data that we generate that we can use for business intelligence, for example, planning services, and so on. So I'm going to stick to the term NHS health data. Now, there may be quite a few researchers in the room. This ain't research data. This data is non-reactive. It was not collected in response to a research question. It's a byproduct. It's like landfill from our clinical and operational activities. So there's a lot of, it's very difficult to work with. If you like, it's sort of like the crushed carbon. And if you can mine and shine this stuff, you can end up with the Kohinoor. But for most of us, we don't have data science skills. It's quite difficult to get stuff out that you can actually do research with and build our AI models. So we've been going for a while trying to, is it the right button? Do I just touch the screen? Oh, okay. That's it harder. Okay, so we've had an electronic patient record since 2017, and the first thing we started doing, apart from delivering patient care, was to form these data groups from the nurses data group, operational reporting or operational delivery, and research and reporting, which is generally the doctor's one. And the work and what's been bridging this is informatics. So trust informatics have been going backwards and forwards through here over 6 or 7 years. And I've done amazing work. So generate sort of things like dashboards, live feeds, audits, KPIs. And if you're a real keenie, you can actually go in there and get some observation level data as well. But most of the data needs of these three groups has been aggregated data. There's been some research activity within this, but the majority of it within the internal data groups is they use it for audit KPIs, dashboards. It's aggregated data. There's not an awful lot of interest in using observational row level data. And there are two other groups in here, not established properly. The Informatics Research Centre in the Henley Business School done a lot of work with our informatics team. And you've seen some of that work presented here today. And then we have industrial partners such as Brainomics, TriNetX, M-Modal, goes on and on and on. We've got a lot of industrial partners. And this has been going on for 7 years, from 2017 to today, or this year. But what we realized was that we couldn't continue like this because it was not scalable. So the activity of informatics, bridging this gap between the data needs of these five groups and getting it out of the warehouse, has a constraint. It has a capacity constraint. And so we, chief exec from above, said, you need to sort this out, boys and girls. And we want you to build a structure that we can fund separately from informatics. And so we spent 2 years on this. And it's taken a long time for us to even get to the delivery group phase, which was this January. And we built a health data institute. So this, the leadership team is, we have a head of data research and advanced analytics, Mayor Dokia. We have our director of research and innovation at the trust, which is Athol Kapila. Myself reporting to the chief medical officer, and we have Baz, who is our associate director of informatics. Now, this was 2023. Everything was fine. We were looking at improving these systems, going out and getting collaborations between the university and clinicians, particularly want that collaboration. get together and do some really fine data science impactful projects. We were some way into that until October of 2023. Sorry, I beg your pardon, before I get that, jumping ahead of myself. And the model we were using was the one that we recognized was translational medicine paradigm. So this is where you have research on the bench, and you try and get it across to the bedside so it's deployed, so that what we're giving the patients is leading edge evidence-based care. And the equivalent in the digital space looks like that. So we've got computers, and we've got Vicky's team, we've got University Computer Science, and many other groups, biomedical engineering, for example. All these various departments within the university have data scientists. And now the focus with the HDI, is to get these digital products across to the bedside. What we found from experience is that we really need to be much nearer to the bench than by the bedside. So what we did is we put the clinician in the middle. And this meant that if the clinician saw that this was something that would hit the sweet spot, then it's bound to get dragged across this gap. If this is esoteric, as you were presenting on Wednesday, then you can see why only 0.05% of the papers that you'd see would actually have got deployed to the bedside. So we want to, sorry, just like myself. You get very close to that screen. So we put the clinician much closer to the researcher, so that we didn't do any research that wasn't going to hit the sweet spot and therefore not be adopted. That's the model we were using. And then in October 2023, the data access policy 2023 dropped as a draft. And this changed everything. Unfortunately, it yanked this relationship and put them as outsiders and called them external users. And that was a big shock for us, because we weren't thinking about a local secure data environment, which is what's mandated with this, because we were going to use Oxford's, but we realized that it was actually going to impact on our relationship with our academics and our industrial partners. So external users, no sharing. There's none of this clandestine thing, hey, do you want a USB stick? Or shoving it across from one drive to another OneDrive. Sharing is not, when this drops, it's not enacted yet, but once this is in, we will not be able to share data. Okay, that has quite marked implications on our relationships, impacts on our relationships. And access could only be granted, so we go from sharing to access, and access can only be granted through a data access committee. This is all in the data access policy. So we set up a project selection group, which allowed where our industrial partners and our academic partners could apply to have access to the warehouse. And with suitable projects, we would sign it off in the steering group. We have to do that. That's going to be part of the regulations. What does access only look like? Well, it's going to be something like a trusted research environment. That looks like it's going to be Azure in the cloud, but really beefed up security. And the researcher will go into this trusted environment to work on the data that we've supplied them. And we colloquially called that the dining room. And it's going to feel like that. If you're used to sharing data with the NHS, this is what the brave new world is going to feel like, because you're going to be confined in a secure data environment, and the data of interest is going to plop into here for you to work on. Okay, so we've got a trusted research environment called the dining room. If we have a dining room, we need a kitchen. And this is a secure part of informatics. It's like Gordon Ramsay. You go in there and you're going to get a meat cleaver or something thrown at you. No one is allowed in the kitchen apart from informatics. And they take the project application and they make the appropriate data extraction from the NHS warehouse, NHS Health Data Warehouse. And then they go through things that informaticians will be very familiar with: normalize it, standardize it, still working in SQL, apply a national opt-out database. If patients have said they do not want to be their information to be involved in research, then we can remove them from the data extraction. And then finally, we de-identify. We stopped using anonymization as a word and pseudonymization. We don't use any of those words anymore. We use the phrase de-identified in context. So there's virtually no chance of being able to identify a patient from this data set, providing it's only ever worked on in the secure environment. So it's de-identified in context. And so the data then goes into the dining room. And at this point, it gets even worse for us in the data science field, in health and digital health, because this is the only data that's allowed to come in. So you are not allowed to bring in GitHub, you're not allowed to bring in open source, you're not allowed to bring in meteorology, for example, it's very important in healthcare when we're planning services, about the winter surges in respiratory syncytial virus and so on. None of that's allowed in. And the only things that are allowed out are aggregated data. So you do all of this work, you build a model, but the only thing that can come out is data visualization, tabulation, and statistics. And that just shoots what we do. It just shoots it. We cannot work with that. I can't imagine when they put the data access policy together, there can't have been a data scientist in the room. There really can't have been. I don't know where NHS England, who they consulted on this, but I can tell you there's a huge pushback from the subnationals. And the subnationals this is a local secure data environment. The subnational secure data environments, of which there's about 13, I think, are working on this. And I can tell you what the future is likely to look at. Providing you get signed off by the Secure Data Environment Management, which is for us is the Health Data Institute locally, you will be able to put other data sets in there, providing we've signed them off. You'll be able to also use some open source from GitHub, again, providing we've taken advice, had a look and make sure that there's no back end which row data can come out the back for patients. And then the outputs. Well, if you train your model, large language model, you want to deploy it, it's got to come out of the secure environment. We can't deploy it from within that. So we are working hard, and the subnationals working very hard on this, and we will copy what they do to have pathways so the outputs will be able to bring out the trained models out and deployed at the bedside. Otherwise, it's a waste of time having an HDI and a relationship with the university, really, because apart from population studies, which is very useful, the data that we hold is very useful because we've got millions and millions of patients. So looking at rare diseases, for example, it has a case use for where the output is only aggregated data. But at the moment, things would look bleak if we didn't know there was going to be some progress. So our mandate in the Health Data Institute is to produce impactful data research, improve patient care and safety, and address health inequalities. Now, Vicky hasn't presented, but some of her work showed huge health inequalities when we looked at the no-show rates in clinic, for example. It not only showed that SE6 were more likely not to show, but also very few of them were accessing secondary care in total. I mean, that's huge. That's beyond quant nerds like us. We need to get the university and our academics who look at the social sciences and behaviours to understand why so few of socioeconomic group 6 access secondary care in the first place. And last of all, if you want to get involved, Health Data Institute at Berkshire NHS.uk. You can find me on LinkedIn, William Flannery. We have a number of things that are very successful that you're all welcome to come to if you contact us through this. Research workshop, we found that very few academics or clinicians know how to access funding for NHS research. It's very specialised, very onerous. And in our research and that's gone now, but in our research and innovation team, we have experts about getting funding. I already have an expert in the room who knows all about this, but we have an education brief. And what we want to do is to get researchers and clinicians together and to learn how to conduct research in the NHS so that we can get funding to do very impactful research. The research cafe is I run, and we run that about 3 times a year. And essentially, what we do is we have a closed environment and we get academics and clinicians together and they're bumping around like this. Some second law of thermodynamics, not much going on. Then I insert curry of an evening, and then we get sort of self-organisation for far from equilibrium situations, and the sparks fly. And we've had quite a few projects come from these informal meetings between our academic colleagues, clinicians, and also our industrial partners as well. And then we have a health innovation partnership that has seed funding. And that's a joint arrangement between the university and the trust. I think the biggest award was about 60,000 or something, and my wife got that, and to do a project in end-of-life care. So that there's money around, but one of the things we suffer from in the HDI is those pilot studies don't attract very much money. Once you've got a proof of concept, as Vicky can tell you about this, once you've got a proof of concept, then you find actually there's a lot of enthusiasm to fund these projects. But it's getting those initial pilot studies done is difficult. And one of the things we can access is the SIF, isn't it? SIF funds through the Health and Innovation Partnership. So that's my brief talk on the HDI.